In the world of medicine, heart surgery is considered to be one of the most advanced, complex, and riskiest surgeries. Most of the cases, patients are in a critical stage. Hence, many look upon reliable hands to perform the surgery. One such renowned cardiologist is Dr. Balbir Singh, Chairman, Cardiac Sciences, Panmax Hospital. Dr. Singh is regarded as the leader in interventional cardiology, a profound researcher who continuously seeks new methods to seek and treat various heart diseases. In his extensive career of over 34 years, Dr. Singh performed numerous complex heart surgeries and is one of the most renowned cardiac surgeons in the country. In the latest episode of ET Health World's Touching Lives, watch Dr. Balbir Singh, who appreciates the trust the patients place in him and the ability to help so many people heal from this serious heart condition.
Dr. Balbir Singh, Chairman of Cardiology, Panmax Hospital, is an internationally renowned cardiologist with more than 32 years of experience. Dr. Singh has pioneered in several techniques in invasive technology. Thank you for agreeing to be part of ET Health World Touching Life series, Doctor. So to begin with, I would like to ask, how did the COVID-19 pandemic affect the field of interventional cardiology, and are there any aspects of this shift that now have become a standard practice?
So COVID-19 brought a lot of disasters, but then it taught us many new things. For example, during the COVID-19 time, during the Delta variant, when there were so many deaths, we used to get calls for heart attacks as well. Now, patients sometimes were COVID positive, sometimes were not tested, and we had to take them because there was no choice. So it taught us that what humanity means, what working for people means. And we were ready to do that because we were very well clothed to prevent a COVID infection. But I remember that I used to come at several times at 2 a.m. and many lives were saved. So the COVID turned around in a huge fashion. Both the population and doctors made them aware that saving lives is so important. And it wasn't that people didn't know about it earlier. The media brought it out very clearly. They showed hospital, they showed the life of a doctor, they showed how nurses worked and how important it is to reach early on time and get treated. So no many things came up, but COVID infection did increase the heart attack incidence. COVID infections did increase sudden cardiac death, which we now started understanding, and it was a very bad disease. And hopefully we are out of it because we had a wave recently and it was very, very, very mild. So I hope we are over it now, but it is a nightmare.
What is the main cause of the steep increase in sudden cardiac arrest in young Indians, which we are seeing now? Like, could people aged between 30 to 40, even younger, having a lot of heart attacks? So why is this surge? Is this anywhere connected with COVID-19 or otherwise?
So first question, is this surge real, or is it that we were not giving importance to this earlier and we are giving more importance to it now? Is this true? So first is it true that the surge is happening in young heart attacks happening, young sudden death? Is it true? Because we need data to show that, okay, in past it wasn't there. So I'll give you an example that when I was a student in our All India Institute, there was a patient who came with a heart attack at the age of 36. The whole ward, the whole doctors were working on him why he had. And now if a 36 comes to me, we don't bait an eyelid, we say, okay, one more. So there's been a huge transition that the younger population is getting affected. And this is real, it is not false, it is not media propagated, it is not something which we can sit from or escape from. So sudden cardiac arrest in young, the commonest cause is coronary artery disease, a blockage in the heart. And it has increased tremendously over the last 15-20 years, which is clear. Now, why is it happening? Because it's the change in lifestyle. The lifestyle is hugely changed. 20 years back, going to a mall like this was so rare. The avenues to eat weren't hardly there. Now, sitting here, I can order whatever you want to have. If you want double pizzas, I can just click and the Zomato will deliver it in 5 minutes, or any other company will deliver. The access to this food and lack of physical exercises, added on stresses of life, there are targets to be met. Each profession has targets. Each aspect, a younger person who never bothered, used to play, no stress, is fully stressed. He's working till midnight, working up the data, looking at what presentation he has to do next morning. So the stresses have increased many folds and the lifestyle has worsened many folds. So it's a combination of both things which has happened, and it is the disaster which we can see now.
Any percentage if you can give, doctor, like, over the years, like how this heart attacks, sudden cardiac arrest has increased with the youngsters? Any percentage if you can?
So I can't give you a percentage, but we looked at our data of before pre-COVID and post-COVID, 2 years hence, to look at heart attacks. They were much more. They were almost 1.5 times more. Now, this doesn't tell me that whether this incidence has increased in the population or the patients have learnt and from the COVID experiences that they should go to the hospital early and they're trying to get themselves treated early. It can be, data can only be generated if you look at the deaths. That can possibly tell us that is the death rate, because that is the simplest data to produce, is the death rate increased? Because people may say that your work has increased, so that's why you're seeing more, or people are getting more aware, that's why you're seeing they will happen. To get a correct answer, we need a very good study, an epidemiological study to look at deaths, to look at this. Nobody has done so far, so I can't give you a correct figure. But visibly, it is yes.
As we have touched upon the sudden heart attacks, I would like to ask about the heart rhythm disorders. How, like, is the level of awareness in the public into this disorder? Like, what's going on into it? If you can just give us some glimpses of it.
People think that heart means heart attack and blockages, which is not true. The rhythm disturbances of the heart are probably the commonest disorders of the heart. The sudden cardiac arrest, which is a rhythm-related problem, is the commonest way a heart patient dies. It's the number one killer of heart patient, not only heart patient, but the entire population. Sudden cardiac arrest is the commonest cause. So our awareness has to increase. Then the third rhythm is atrial fibrillation, which beyond the age of 60, it increases exponential as the patient ages to 80s or 90s. Now with the lifespan increasing, the atrial fibrillation incidence will also increase. Atrial fibrillation can cause heart failure and strokes. So we have to be aware about atrial fibrillation, which is an irregular rhythm of the heart. So heart rhythm disorders can be also genetic, and in those cases it can lead to sudden death, and we have so many series of patients who have been saved out of this kind of a problem.
Like, what kind of steps has to be taken? You said it's genetic. So like, if I had a kind of a this has been there, this heart rhythm disorder has been there in my family, so when should I go and do the heart checkup? Like, what kind of SOPs one has to take?
So heart rhythm disorders can be very benign, like simple missing beats, to very lethal, which can be sudden death. So there's a vast spectrum. So any family member, any past history of sudden death has to be investigated fully. Has to be. There is no escape from that. That if somebody in the family, a first degree relative, died suddenly, the entire family should be screened. Then, because we'll pick up so many things which can be treated.
What kind of age limit, like what age may one has to go and do this kind of a checkup?
This is a very good question. Now, there is a mandate in many countries where when a child goes to the school, his ECG is done. ECG is such a simple screening tool that it can pick up abnormalities in so many children which wouldn't have been seen. Then there is a condition called hypertrophic cardiomyopathy. If one member's had, every member has to have an echocardiography because you can pick up. We recommend that it should be done as early as possible, as early in the age as possible, and repeat at 14 years, because if somebody is not inherited that gene at 14 years, he's unlikely to get that gene. So we do that screening for everybody.
A study published in the European Society of Cardiology has found that people with severe COVID are 16 times more likely to develop ventricular tachycardia within 6 months. So is this true? And for Indian conditions, is this true? There are a lot of studies which are coming up, doctor. We are not knowing, we are getting confused. So if you can just throw some light on that.
Right. So this is true. First, it is true. So there is data to show that in the Chinese population, when they had the COVID for the first time, they did a lot of good studies also at that time. They had some patients who died. They picked up their hearts and to look and see if the virus has entered the heart. It had. So virus was embedded in some hearts, which they studied. The second thing that has been studied in some universities is biopsies of these hearts and finding what is called as myocarditis. So myocarditis is an inflammation in the heart, which you may not pick up on routine ECG or echo, but it is picked up on MRI or biopsies. Now, this myocarditis has been associated with ventricular arrhythmias, ventricular sudden death. So it has been increased. Now, when will this proponicity? So somebody says, I had COVID in 2020. What is my chance now? Hopefully, he would have been now off the risk. But still, COVID has a lot of enigmatic things which happened. This virus, nobody realized could be so lethal, and it was so lethal. COVID long syndrome in some patients is really bad. So what it has more to unfold, we don't know. But it seems anybody who's been 2 years behind this should be over with it.
What are the increasing challenges, like if you could talk about interventional cardiology in the current times that's adding to the strain, like, and how is technology and new techniques are helping to bridge these challenges?
Right. So it's a very exciting field, interventional cardiology. The learning never stops. I go home, I come at 8:30, leave the hospital at 9:30. But as a routine, I would study something for 1 hour before I go to sleep. Because the challenges of interventional cardiology are huge. You can change the outcome of the patient. You can actually cause more problems if you don't do the procedure well. So both aspects are there. So the new procedures need more learning, more reading, and more you read, the better is the outcome for the patient. So it is very exciting field. So for example, on this Saturday, we did a patient who was about 78 years old. He had a leaking valve. He had a bypass surgery in the past. We clipped his mitral valve. The procedure took about 1 hour, but it was thoroughly studied what we have to do. We had a CT, we had 3D imaging, 3D TE, so all that technology is really helping. So that clip was done without surgery, and the patient is discharged today without any leakage in the valve. So these are some of the things which were unimaginable a decade back. With that, it could advance so much. The 3D imaging it's a great tools that we are developing.
Adding to that, if you can talk about the AI, artificial intelligence in interventional cardiology, most of the doctors are so excited about it. What is so exciting about it?
So as of now, the applications are not too many because the field is new. I'll quote you an example of one of my friends who traveled from Mayo recently. He said that Google wanted to see the data of Mayo Clinic, and because Mayo Clinic keeps immaculate records. They have follow-up, 10 years follow-up. So they said, okay, give us only the X-ray and ECG of a patient. The simple thing, nothing more. Each patient of X-ray ECG is preserved in Mayo Clinic. And tell us what happened to the data on 10 years for the machine learning of those patients. And then we do a prospective study for the next 10 years. So they gave them the data. This is the X-ray, this is the ECG, and this is how the patient, these were the patients who died in 10 years. This data was pushed to machine learning. Then the next 10 years data, only X-ray and ECG was given to the machine, and it was to tell how many deaths were there. And it predicted correctly to a tune of 98%. So there is so much there. So the doctors were saying that we want to know what did that machine find on the ECG and an X-ray which our eyes did not show me.
Yeah.
So they want to say that there has to be some feedback from the machine to tell us that, look, this was the way which was wrong. That's why we predicted a death and we missed it. So it is going to be a game changer. When it will happen, I don't know. At the present moment, it is not into clinical applications, but it will start. For example, radiology. Yeah. It is completely now AI based. AI makes the diagnosis. So echo will be the next target. On cardiology, echo will be next target. We are working with one company, an American company, and a joint project with UCLA, California, and us. We are looking at some maps which we generate on electrophysiology of the rhythm disorders, the maps that we generate, feed it into that, and tell the machine to tell us which were the right things we did and which were the wrong things we did. So it's in the infancy. So once we get into it, it is going to be a great relief for us.
Going on, I would like to ask about talking about technology. We see a wide range of smart wearable devices used by many of us. Like we are like having that and seeing our, checking our ECG and everything. So, do you think these electronic fitness gadgets are helpful for tracking CVDs, or does it come with a risk? Because everyone is like going after it.
Right. So I'm wearing one. So I can
But
tell
you're a
you,
cardiologist.
I'm telling you that they're very useful.
Okay.
So I advise many of my patients that when you get those symptoms, let us see what happens to the ECG. ECG in some of them was very accurate, very well tested, FDA approved. The newer device is going to tell us BP, the BP, the diurnal variation, the 24 hours BP trend, the saturation, pulse, and ECG is already there. In my opinion, the future lies in every human being having one such chip, which will send signals of an alert if it detects one, which will go to some place nearby, a hospital, a nursing home, or even a police van standing there, who can come and help that patient. Such alerts are possible. AI generated impulses from ECG have shown that there are some alerts which can prevent sudden deaths. The help can reach, if the help can reach soon, they can help. So every human being within 10 years, within the decade, maybe 5 years, will be having some kind of a chip, computerized chip, which will send signals to the nearby hospital and will help us actually grab an opportunity to save a life.
But is there no risks with such devices, you say, as of
So,
now?
risks as in to the body?
To the body, or like whether it's giving us the correct information, because everybody is choosing it without a clinical approach to it, then
Right. So,
the
some
risk.
of the applications are now tested.
Okay.
We have papers written on it
Okay.
and approved by FDA based on those papers. So, some of the applications are that good. So, it will evolve. It is not the end of the story. It is going to evolve. So, some companies are very good, some may not be that good. So, all cannot be put into the same basket.
So, adding on to it, like how much are implantable cardiac pacemakers safe? Because as there are cyber security issues also, like there is an FDA, US FDA. There was a recent study also. They said like it can be hacked to run the batteries down, or even after the patients alter the patient's heartbeat. So that is like little worrisome. So
Okay, so as we advance, we have to take care of this hacking business also. So the devices are computerized, ICDs, pacemaker, they are all computerized. They are now Bluetooth enabled. That means the data is connected in the phone app and then transmitted to the center. Fortunately for us, it's not a both way process. That means the data can go out, but nobody can manipulate the data in the device. So it's a one-way traffic. So they are very secure. It was correctly pointed out by you that this has been a concern by FDA, but it has been tested that nobody can manipulate. Yes, now changing the heart rate or changing the battery, for that you need the programmer. So there's a programmer which is in doctor's office. So can somebody buy this programmer and go and do it? Yes, he can do it. But he has to access the patient by putting that program on his device and then manipulate the program. So it requires a complete coming to the patient's home, taking that programmer,
with the
putting,
patient knowledge only, one can do anything.
yeah,
Is it
but it is like doing a murder. He can go home and kill him with his knife. So why take a programmer? If somebody has that wants to access the pacemaker, if he wants to kill that man, he can do many other ways rather than through the programmers. So he needs his consent. The programmer has to be with him. Only then you can manipulate the heart rates.
So, asking about the costs now, like is cardiology becoming more affordable in India? Like a decade back and now? Like how is the scenario? And also when you make cardiac surgery affordable, how do you ensure quality and make cardiac surgery safer? Because when you're saying affordability comes with cost.
So affordability, whether the costs have come down in the last 5 years or not, is first question. The question is that Government did a great job by capping the stent pricing to 30,000 rupees, and they may be considering some more cappings, which has resulted in procedure getting cheaper. This is true, absolutely true. But there are other procedures which are upcoming and new technology. They are not cheap. The companies don't want to sell products cheap because they know that there's so much demand in Europe and America that even if they don't do business in India, it doesn't matter to them. So they are not coming down on the niche varieties of work. Stents have come down. So made in India would be a great thing if we have to really bring down the cost further. The second thing is, will the quality suffer if the costs start to be? No, it won't. I've seen my colleagues who worked with me and then went to small towns to practice where they're doing much cheaper angioplasties than we are doing. They're doing a great job, and they come and discuss cases with us, and they're doing a great job. And then this government scheme of Aadhaar. I have a close friend in Jammu, and I went for a workshop there, and there were patients who were lined up. There were 7 of them lined up for complex procedures, and there were 7 more who were saying that they are waiting, that in case one is cancelled, they will take in. This never happened in India. This is the first time I saw this kind of a scene because of the Aadhaar card. Because in Jammu, everybody has an Aadhaar card. And this is fantastic. This is great for the population, and will really be doing, as I see things, and with our government thinking of health for all in the future, it can be a great exercise.
So, doctor, you mentioned that made in India devices. So, what kind of devices should come in, like made in India, like the pacemakers or what?
So, as of now, pacemakers are not there, balloon pumps, any niche device is not there. So, people ask me, is the technology so complex that India can't make it? I said, if India can make a satellite, if it can launch a rocket in the space, why not a pacemaker? I think it's the mind we have to spend money into it to.
So, what would be the cost difference if it's made in India?
It will be multifold difference. It will be difference by multiples, not 50%. It will be multiple difference.
So, I would also like to ask, like among the medical subspecialties, cardiologists work more hours than those in many other medical specialties and face increasing burnout. So, how do you manage or handle such burnout crisis?
So, it is a very simple answer that if you enjoy something, you love it, you will work for it. We just enjoy it. It is so much thrilling. You know there's a patient's life on the table. You know it could go wrong if you're not into the procedure. So we just enjoy it thoroughly. Every patient is different. He throws at us several different challenges, which we enjoy and be happy with it.
And also, like, what are your views on the future of cardiac surgery? As you said, there's a lot of technology things are coming in. But keeping in view of young surgeons, if you want to say something, and what will also impact robotic surgery, like what kind of things would bring in the cardiac, if you can just.
Right. So the cardiac surgery. Now the surgery work will never go down. That's my belief. But youngsters are not taking cardiac surgery as a specialty, which is very surprising. I have seen many institutes, the seats go vacant. Nobody has taken the surgical program, which is unfortunate because there is so much, for example, pediatric surgeries, so much can be done. There's so many new procedures coming in pediatrics. Similarly, in adult surgery, there will be complex procedures. There will be a patient who will have multiple stents, and now there is no scope for a stent. He will go for surgery. Heart transplant has to pick up tremendously than what it is doing, LVADs. So there is so much scope for surgeons. So it is not that surgery field is finished because the cardiology has grown. It has tempered a little bit because the surgeons feel the scope is less now. Youngsters are not as enthusiastic about cardiac surgery what they used to be in past, but the surgical work will not go down. As far as robotics are concerned, robotic will have a place ultimately. Unfortunately, in the last 10 years, robotic surgery in cardiology has not really picked up because of long procedure times and some complications which have happened. So surgeons have not taken on well with robotic, but some centers in the West are only dedicated to robotics and they do very well. So I think probably more experience and more new robots may make a difference. As of now, it's a kind of backseat. Like prostate, like lap chole and other procedures, robots are far ahead. But in cardiology, it's a cardiac surgery there.
Which one habit should people strictly refrain to have a healthy heart?
So youngsters should stop, quit smoking. Everybody should quit smoking. One thing which can change the whole scenario.
How do you tackle patients who are Dr. Google or ChatGPT informed?
So they are actually better because they are fully informed. They know everything about there, and you have to just discuss with them that you're right on this, you're right on this, but you're wrong on this. Because they've done a homework and they know what complications of procedure can be. I'm happy with it.
You have no complaints?
No complaints. I want an educated person. I want an educated patient.
But aren't they more informed or misinformed than
Sometimes yes, but we have to clarify that. And I'm very happy to discuss such problems with them because they are educated. And so they will understand and react to you by saying, okay, this can have this complication, I'll be careful.
the 3 changes you want to see in patient-physician relationship in a digital era?
So in a digital area, the expectations from the patients are huge. And the physician who's sitting on the other end sometimes does not understand the problem as well he can understand when both are sitting next to each other. So all serious illnesses should not be attended through a video consult. Because a physician has a high chance of making errors. Follow-up visits are simpler, easier, because you know you have a file with you, you know what happened to him and what your expectations are by asking those questions. But a new patient can pose several challenges which can sometimes be difficult for us to answer. So sometimes when I'm not able to answer the questions, I say, please come, I may make a mistake. And sometimes they have a serious problem, I say, please rush, get him tomorrow morning. So it has challenges, but it has advantages also.
Thanks a lot, Doctor, for taking out time and giving us elaborate answers for the questions which we had asked. Thanks a lot.